get started. So hello, everyone. I'm going to go ahead and just get started right on time. This will be recorded for anyone that joins later. And so my name is Dr. Alyssa Cooper, and I'm the resident naturopathic doctor here at Living Wellness Medical Center under Dr. Turner. And today's topic is one that is very near and dear to my heart, and I'm so excited to be presenting on it. So during my naturopathic training in Portland, Oregon, I completed a 6-month course in integrative pelvic floor therapy, and taking that and going through that mentorship really ignited my passion and sparked my interest in pelvic floor health, and integrating that to be a key focus in my future practice. And so a reason that I think that this topic is important is because I really aim to empower individuals and my patients to connect with and learn more about their bodies. And the pelvic floor is a region that tends to be overlooked and can be overlooked in medicine. And if you do have any questions throughout, please feel free to type them in the chat, and then I'll answer them at the end. I'll try to get to all of them in just a little Q&A section. So let's go ahead and dive in. This is a little overview of what we will talk about today. So first, we'll go over what the pelvic floor is, and then we'll dive in a little deeper into the different layers of the pelvic floor. I will try to keep that short because it's a lot of anatomy, but it's really important to know. And then we'll touch on what pelvic floor therapy is, discuss hypotonic pelvic floor muscles versus hypertonic pelvic floor muscles, and then kind of dig into indications, which would be like symptoms or different conditions that you may have that would suggest that pelvic floor therapy might be for you. And then I'll overview some cases at the end. I love to throw in cases just to kind of show like that pelvic floor therapy is really for everyone, regardless of their age. And again, if you do have questions, just put them in the Q&A throughout. I won't answer them throughout, but I will answer them at the end. So let's go ahead and get into it. So the pelvic floor, it's a question that I get asked by patients a lot. If I ask them about pelvic floor function or dysfunction, they're like, what is the pelvic floor? And so it's made up of numerous muscles, ligaments, and connective tissue. And if you think of the pelvis as a home and your organs in the pelvis, such as your bladder, your uterus, or prostate and your rectum, the pelvic floor is really the foundation of that home. And some of these structures form slings or sphincters around the organs, and connective tissue to help support them in your body. And so all of these intricate muscles really work together to support bladder function, support bowel function, and then they have a very specific involvement in sexual health. And so those muscles also work in conjunction with the abdominal muscles, our back muscles, and even our diaphragm. And there's some connection that's been discussed with the connection between our pelvic floor muscles and the jaw. I won't go into that too much today, but something to consider because I do see it a lot in my patients that have tension in their jaw. They also tend to have tension in their pelvic floor. And so just as you would have trigger points in your shoulder muscles or your back muscles, the pelvic floor muscles can have trigger points as well. So I love this picture. It's very simple, but it kind of shows the connection between the diaphragm and the pelvic floor. And with correct breathing, when you breathe in, your diaphragm lowers in your body, and that's going to provide some pressure in the abdomen and a little bit of pressure on the pelvic floor. And then when you exhale, that pressure releases and the pelvic floor lifts slightly. With shallow breathing, what can happen is that the pelvic floor and the diaphragm are not working hand in hand, and they're not working together. So when you're shallowly breathing into your chest or into your shoulders, where your shoulders are lifting more than they should when you breathe, what can happen is that can cause some increased abdominal pressure and cause the pelvic floor to have that bearing down sensation. And so something that I like to do with my patients just to see like how they naturally breathe is actually go through this exercise together. And so if everyone will just breathe with me. First, we're going to do an example of shallow breathing, and I'll only do this twice because I don't want you to get a habit of this. So when you shallowly breathe, think about breathing into your chest and into your shoulders and not into your belly. So when we breathe in, if you notice, your belly button sucks in and it's actually coming in towards your body, and you're having that bearing down sensation in your pelvis. So if we do it again, you might actually notice the urge to urinate here, depending on your pelvic floor. And what we want to do instead is really breathe into the belly and do that belly deep breathing. And so this time, when you breathe in, try to expand your belly instead of sucking it in. And that will show you like how that deep breathing is not going to cause that same bearing down sensation in the pelvic floor. So if we do this together, try to breathe into the belly. So when you do that, if you notice, your belly is going outward, having a sucking in sensation. That sucking in sensation is actually like holding our breath, and that's not how we should be breathing, and that is something that can contribute to pelvic floor dysfunction. So now this picture, I love this picture because it shows the connection of all of these organs in our body and the connective tissue. And I don't know if anyone else, when they were younger, thought this, but when I was younger, I kind of just imagined my organs like floating around in my body and not being, held down by ligaments and muscles and other connective tissue. And so this picture kind of demonstrates the relationship between them and those the sphincters around them, the sling that I was talking about earlier with some of these ligaments. And this photo is specifically in an individual with a cervix and a uterus. So if an individual had a prostate, then that would be located about around where the cervix is in this picture. So just keep that in mind as we, move forward and look at the pictures. So this is the little anatomy lesson. So superficial, layer 1 of the pelvic floor muscles. This consists of the ischiocavernosus. So if you're looking at the picture to kind of orient yourself, the top is the pubic bone, and then the 2 lines of that top triangle, that's the ischiocavernosus muscle. And then the bottom of that triangle is the superficial transverse perineal muscle. And then the circle in the middle, the blue dot is the urethra, and then the white opening is the vaginal opening, and that bulbospongiosus muscle surrounds that. And so the bulbospongiosus is a muscle that gets a lot of attention in pelvic floor work, typically, because that is the muscle that will contract or will engage with initial penetration. And so some people that have pain with tampons, with speculums, just any insertion, that muscle is in such a state of contraction that it's not able to relax, and it causes pain. And something that's interesting about all these muscles is that many of them are innervated by the pudendal nerve. And this is like a little language history lesson, is that pudendal comes from the Latin word pudenda, which means external genitalia, which is derived from the term pudendum, which means parts to be ashamed of. And so kind of back to like what inspired me to really get into pelvic floor work and discuss it with my patients is that sense of shame that I feel like we're taught in the society to not think about, not talk about, our pelvic floor muscles and about sexual health. And so that's something that I really try to combat with my patients and bring up and ask them about and normalize it, because it's so important. And if these people are in pain, or if anyone is in pain from these muscles, like that needs to be addressed. And yeah, their health is really important to address. So little side note on the word. And then layer 2. So this is the compressor urethra, the external urethral sphincter, and then the urethrovaginal sphincter. And so a lot of sphincters are in this layer 2, and we have internal sphincters, which are involuntary, so we cannot control them. And then we also have external sphincters, which are voluntary, which we can control. So that's kind of just a nice little side note to think of moving forward. Those external sphincters, because of the muscle they're made of, we can control them. And then layer 3, these are some of the bigger muscles, but also there's so many of them involved in the pelvic floor. So we have the coccygeus, and then we have the levator ani group, which is the pubococcygeus, the puborectalis, the iliococcygeus, and the obturator internus. So say all of those words fast. It is a mouthful. And so here you can see on the left picture that those muscles, whereas in the right picture, they look a little more posterior, are actually like what make up the pelvic bowl. And so it's really interesting just to see like all the different structures. And when I first saw this picture, I was, shocked. I was like, wow, there's so many muscles. And I didn't even learn this in my regular curriculum. Like this was specifically what I learned in that pelvic floor mentorship. And then if we go to this next picture, I feel like this is a nice picture to show how those muscles can be accessed for an internal exam. And so pelvic floor does consist of some internal work for some individuals. It doesn't have to be for all individuals. And you can see how there are so many different muscles that can be having trigger points, that can be in spasms, that can, have different pain sensations, or the opposite, might be weak and might not know how to contract. And if we go into the next one. So now we'll talk about just a general overview of pelvic floor therapy. So thank you for sticking with me for the little anatomy lesson. So pelvic floor therapy itself is a very comprehensive technique that's used to treat pelvic floor dysfunction. So it may involve lower abdominal massage, back massage, different stretching techniques, and then also internal pelvic floor work. So the pelvic floor therapist or practitioner would assess the muscle strength to really determine if strengthening exercises are needed or if relaxing exercises are needed. And there's two different types of fibers. There's the slow twitch fibers, which are more for, prolonged effort, and then the fast twitch fibers, which help control our sphincters when we have, when we're coughing, when we're sneezing, and we need to, tighten those sphincters to not let any urine out. And so one thing that I would love to highlight, that if you don't take anything else away from this, is that it's a misconception that everyone should be doing Kegels to strengthen their pelvic floor, because some people might have a hypertonic pelvic floor, which we'll talk about soon, and their pelvic floor is too tense and strong and does not need to be strengthened and actually needs to learn how to relax. And so that's something to keep mind of, because I know I've seen a lot of information out there of like, do your Kegels and strengthen your pelvic floor, and that is not the case. So keep that in mind. And also, I just wanted to, really highlight that pelvic floor dysfunction is so common, and statistics say that 1 in 3 women at some point is going to have some form of pelvic dysfunction in their life. So just keep that in mind moving forward, and know how common it is. And a lot of people, as I was saying earlier, really hold tension and stress in those muscles and are not aware of how to relax them. And so that's also a point of pelvic floor therapy that I like to work on with my patients. So like I was saying, in addition to internal work, there's also external work. There's abdominal massage or uterine massage. There's the psoas release, which is accessed typically anteriorly. And then there's some trigger points along the iliacus, which is a muscle around our hip bones. And then diaphragm release. This can be very intense for some of those patients that may have been breathing just like shallowly for their whole life, and their diaphragm is not trained to, fully relax and to lower. And then also some low back muscle release. So that's quadratus lumborum. And a typical pelvic floor session will have a little bit of both, some internal work and some external work. But again, it really depends on the patient, how severe their symptoms are, and where they are in that treatment process. So now we'll go into hypotonic versus hypertonic. So pelvic floor muscles can be either. They can be hypertonic, meaning that they're too tense and too strong, or hypotonic, meaning that they have weakened. And there's many things that can lead to a hypotonic pelvic floor. This is a list of just some common ones. So first is pregnancy. So with pregnancy, there's an increased abdominal pressure, and that pressure is sitting on those pelvic floor muscles, causing them to weaken over time. Childbirth, especially if it was difficult or there was prolonged pushing involved in childbirth, that can lead to injury of one or multiple of those pelvic floor muscles. Excess weight just goes back to the extra abdominal pressure in the cavity. And so something to consider. Menopause, typically from low estrogen status. So low estrogen status can lead to vaginal atrophy, which then can lead to weakened muscles. Hysterectomy. So the thought around that is more so around the disruption in the nerve supply and then also just in the anatomy, because you're removing the uterus and potentially other structures as well. And with that, you may have an increased risk for pelvic organ prolapse or urinary incontinence. We have low back injury. That's really from disruption of those muscles again. So much connection between the low back and the pelvic floor. And then chronic constipation, which can be related to hypotonic or hypertonic. Hypotonic, it's usually from chronic constipation, from that overuse and that straining and that pushing, just leading to poor muscle contraction. And, your body's in this state of constantly bearing down. And so those muscles learn to weaken. Next, we have a hypertonic pelvic floor. So we'll shift into that. And so some signs of a hypertonic floor are more of that pelvic pain, pain during intercourse, hip pain, low back pain. We'll dive into those a little bit deeper soon. But also just in general, hypertonic pelvic floor muscles, your muscles have learned to be in that state of contraction and are unable to relax. So some things that can lead to hypertonic pelvic floor can be pelvic surgery, which could be from adhesions and chronic muscle contraction. Improper posture, so chronic sitting. Excuse me. So chronic sitting that can engage those muscles and just also lead to a state of chronic contraction. And history of dance, Pilates, gymnastics, I see this so often in my patients. Anything really that involves the core and really has an emphasis on that core work, because some people, when they think of, engaging their core, they just suck in and they hold their breath and they don't know how to engage their core while also breathing. And so, that's a very common thing that I see in patients, is that history. And then pelvic trauma or abuse. So that could be, trauma from a car accident or like a physical trauma. That could be assault, leading to just that hypertonic contracted state. A lot of patients also have anxiety, and just anxiety in general has your body in that, tense state for prolonged times. Also, referral pain to the pelvic floor from nearby organs. So that could be from the bladder or from the bowel. And then again, I kind of wanted to highlight this one, especially with that pudendal nerve, emotional blockage due to shame around sexuality. So depending on someone's background, depending on how they were raised, they may have some shame or some disconnection with their pelvic floor and just don't know how to, notice that awareness and how to bring their attention there. And so that's something that I also work with patients on is, teaching them how to engage those muscles, how to relax those muscles, and what that feels like in their body. So next we have urinary incontinence. I really wanted to give this its own slide because a lot of times people think that urinary incontinence is from a hypotonic pelvic floor, from the muscles being too weak. And it absolutely can be because those muscles have weakened. And when you get that urge to urinate either through the urge incontinence or through the stress incontinence, which is more sneezing or coughing, they're unable to really control that external sphincter and they'll have leakage. But it can also be from a hypertonic pelvic floor, which means that their body is in the state of contraction and they don't have the ability to relax and then contract when they need to. They're already contracted when that sensation may come on. So next, this is some indications for pelvic floor therapy. So these are either conditions or symptoms that you or people may be experiencing that would indicate that pelvic floor therapy might be the right fit for them. So first and foremost, definitely pelvic pain. I would say that's the most commonly known reason for seeking pelvic floor therapy, but there's so many more. So under pelvic pain could be caused from many different things. So we have endometriosis, which is a condition where there's endometrial tissue outside of the uterus, leads to very painful cycles for people or just pain throughout the month unrelated to their cycles. Pelvic congestion syndrome, which is kind of where the valves, the veins, the valves are not working properly. So there's an overflow or a stagnation of blood in those pelvic vessels. Fibroids, which can be in the uterus, and those are responsive to hormones. recurrent ovarian cysts for people that have PCOS, interstitial cystitis, which is an inflammatory bladder condition, and that could cause bladder pain, which is then referred to the pelvic muscles, causing either, hyperfunction of those muscles or hypofunction of them. And then recurrent cystitis, so recurrent UTIs, that's something, again, that I see a lot is, a UTI or a bacterial infection like bacterial vaginosis that causes some lasting pain and irritation for people. And then irritable bowel syndrome or disease, so kind of going more into that bowel section, same with celiac disease, and then fibromyalgia. So those are some potential causes of pelvic pain. Again, there are so many causes of pelvic pain. Some more indications, so pain with intercourse, pelvic organ prolapse, whether that's cystocele or rectocele, urinary incontinence or urgency, as I mentioned, fecal incontinence, constipation, postpartum recovery. And these are in no particular order because postpartum recovery is, again, kind of right up there with pelvic pain as like one of the top, 3 reasons that people seek a pelvic floor therapist. And then also low back pain and hip pain, because again, those muscles are so connected. A lot of times when I'm doing pelvic floor therapy with a patient, we'll find a trigger point, and that trigger point will radiate specifically to a spot in their hip or a spot in their back. And that gives us some further information on where to direct the therapy. And then some indications for pelvic floor therapy for males. Didn't want to leave you all out. Pelvic pain, again, could be from many causes. Urinary incontinence, erectile dysfunction, constipation. So potentially, urinary incontinence related to the prostate and those muscles surrounding the prostate weakening over time. So I don't do pelvic floor therapy on males. That is not what my training was focused in, but if you are a male and you're interested, we can definitely get you, connected with a pelvic floor therapist in the area. So just let us know if you're interested in that. And then contraindications for pelvic floor therapy. So a lot of these are, in the moment. So an infection, if there's an active infection going on, and before I do any internal work, we always take an external exam just to see, if everything is looking healthy. So during an infection, we would not want to do pelvic floor. Non-consent. I mean, that one speaks for itself. If someone does not want to consent to pelvic floor work, then obviously we're not going to do it. And as I mentioned earlier, pelvic floor is so multifactorial that we could do so much externally as well if people are hesitant to have any internal work done. So that could be, that lower abdominal massage, back massage, learning how to release those muscles, learning how to breathe properly and just like relax those muscles or strengthen them if that's what the person needs. First trimester of pregnancy, we're not going to do pelvic floor. Some therapists will. That's something that, I would not do. And then less than 6 weeks postpartum. So we want to wait till that 6-week mark postpartum to do any of the strengthening exercises typically for those postpartum women. Heavy bleeding during the appointment. So that's like excessive bleeding. If you are, at the end of your cycle and you come in, we can definitely do pelvic floor, but during it, it might just make it more difficult. And then also very friable vaginal tissues. That's a further contraindication. So cases. So now we'll dive into a few cases and then we'll get to some questions. I just love throwing these in there for people to, potentially resonate with and know that there's people like them that are struggling with pelvic floor dysfunction. So case 1, so this is a 60-year-old female. She's 8 years postmenopausal. She has 4 children. All of them were vaginal births, and her main complaint was urinary incontinence and mild pelvic organ prolapse. So on exam, this was a case where it really exemplified that hypotonic pelvic floor. And we had to work on correcting the vaginal atrophy as well that this patient was experiencing through suppositories and through different lubrications, and really make sure she wasn't using any irritating soaps, detergents, or topicals. We worked on strengthening the pelvic floor through Kegels and exercises like core exercises at home, and made sure that during those core exercises, she knew how to breathe properly. And this patient, got so much better, and it did not take that long to notice improvement and just really start engaging those pelvic floor muscles. And that's one thing too that I love about being a naturopathic doctor with this training is that I can help address, the vaginal atrophy through lubrications and through different, herbs and strategies. And it kind of just expands like my toolkit of things that I can offer. Next, we have an 18-year-old female. So she had a history of gymnastics for the last 10 years. She had really heavy, not so much heavy, more painful menses. And her pain was about an 8 out of 10 for the first 2 days. And she couldn't use a tampon during those days because the pain was so bad. And she also had pain with intercourse on both superficial and deeper penetration that was worse on the right side. So this case is like a perfect example of that hypertonic pelvic floor. She had the history of gymnastics. She, was so used to sucking in her core that those pelvic muscles just got very tense and hypertonic. And so we worked very slowly together, and we used vaginal dilators to get her body used to relaxing in that state. We also really worked on that right side. Her psoas was extremely tight on that right side, so we worked on releasing that. And again, this therapy, this one took a little bit longer to see benefit just because there was so many things, to take into account. But again, this patient definitely noticed improvement. And it was also great, as an 18-year-old female to really start now and teach her these things now that she can take into the rest of her life. So next, we have a 45-year-old female. Main concern was urinary incontinence. She sat all day for her job and did not feel connected to her pelvis and had high anxiety and stress levels. So this is an example of when you have a hypertonic pelvic floor from that sitting, from that disconnection and anxiety, and leading to that urinary incontinence. And so in her case, we really worked on learning how to relax those pelvic muscles, doing some at-home relaxation techniques outside of the visit, and working on the stress and anxiety from a naturopathic perspective as well. Case 4, this is a 30-year-old female. So her main concern was urinary and fecal incontinence, and she was 6 months postpartum. And then ever since, postpartum, her intercourse just did not feel the same. And so in her case, this was from a hypotonic pelvic floor. So from those muscles weakening through childbirth and through pregnancy. And so this one, we had to work on really strengthening again the pelvic floor. And fecal incontinence is not an uncommon symptom as well with hypotonic pelvic floors because those muscles are just relaxed and they're not, working and engaging properly as they should. And so I wanted to do an example of just like different strengthening and relaxing postures. This is not medical advice. You definitely need a pelvic floor assessment before, deciding if you need strengthening or relaxing postures, but just like to exemplify that, I wanted to put some. So strengthening, we have planks, we have bridges, the toe taps, the kneeling bird dogs, and then relaxing postures, that happy baby pose that we love to do in yoga, the butterfly, and then also the reclined butterfly. And so in general, I just wanted to overview like the flow, and specifically the flow if you're interested in getting pelvic floor work here at Living Wellness Medical Center. So if you are not a patient, you would have to establish as a new patient. And then we would do a 45-minute initial pelvic floor consultation. The treatment really depends on the person. It's typically 6 to 12 weeks, sometimes longer. Sometimes like we can do weekly and then spread out to every other week. And those are typically 15 to 30 minutes, depending on what we're doing during that visit. And then in addition to the pelvic floor work in office, there's at-home pelvic floor exercises, recommendations for potential herbs, suppositories, at-home treatments, different things to increase the circulation and the awareness to the pelvic floor. And yeah, if you are feeling called to work with me or, get more information, please don't hesitate to reach out. And then I have this question and answer section. I know I just hit 30 minutes, but I'm going to see if there is some questions. Is there such a thing as trauma-informed pelvic therapy? Yes, there absolutely is. That was a part of my training as well. And that kind of goes into the area of without starting pelvic floor, I would never just do pelvic floor without getting someone's history. And so not like the detailed history unless they wanted to share, but that's part of that initial assessment to see if there has been, any pelvic abuse, sexual abuse that an individual has gone through, and really working on that together or in conjunction with a therapist before doing any internal work. One thing that's really important too that I tell all my patients is like, while we're doing pelvic floor work, if it is internal, the importance of keeping our eyes open and keeping ourselves aware, even though a lot of the times we're releasing, specific trigger points. What we're trying to prevent is that person from potentially, disassociating and kind of like, going into their body, which can happen with people that have a history of abuse. So it's definitely a really great question. And yes, it tends to be a more of an ease into it, or it's just all external work. And even external work, can be triggering for some people. So really just having that conversation before anything is done and before there's any touch happening. So great question. I know I had a patient ask me a question in office that I wanted to bring up. So the question that they asked me, and we'll do this as the last one, was if you can still be having intercourse in between the pelvic floor visits. And that is definitely dependent on the patient. So if the patient is very, in a hypertonic state, then that is something that, if that's causing increased pain, then we may have them avoid just the penetration part of intercourse. Like, of course, there can be many other forms of intercourse. And so it really depends. It's not a contraindication unless, we're doing different suppositories or unless we're really working, and working up in size with dilators. But again, that was a really good question that I had a patient ask me, and it's really case to case. So yeah. Anyways, that is all. So if you have any questions, you can reach out to me. You can contact Living Wellness Medical Center specifically. We can get you set up with a free meet and greet or with a new patient visit or that consultation if you're already an established patient. So thank you all for being here. And yeah, this was so exciting. I love talking about this. I would talk about it all day long if I could. So if anyone wants to chat more, just reach out to us. All right. Have a great weekend.